All right, good evening, everyone. Thanks for joining us on this webinar this evening. We appreciate you taking the time this evening to join. We are joined tonight with Dr. Kevin Denehy, Bluegrass Orthopaedics Joint Specialist, and we're really excited to hear about his new robotic-assisted knee replacements that he's doing now in our surgery center. Just a couple things about the webinar. We will have a couple polls that we'd love to hear some responses. That when we share those, feel free to click the responses that are your answers. And then on the chat box, feel free to ask any questions. We will definitely try and hit those all at the end and make sure we get you taken care of. So without further ado, Kevin Denehy, and it's yours.
Oh, great, Andrew. Thank you for that introduction. I want to thank everybody out there for taking the time to tune into this webinar tonight. The era of COVID, we're going to do things a little bit differently than we would otherwise. And so tonight we're going to do this virtually and go over some new exciting technology that's been brought to our outpatient surgical center, Bluegrass Orthopaedics. That I think is really going to revolutionize the way that we're able to perform partial and total knee replacement on our patients. Just like Andrew said, even though we're doing this virtually, I really would encourage you to participate in the polls and ask questions in the chat box, and we'll do our best to answer questions as we go along and try to keep this as interactive as possible, even though we're doing it virtually. So like Andrew said, we're here today to talk about this new technology that we've had brought to our surgical center called the Mako Striker robot system. It's a pretty unique device that allows us to perform knee replacement surgery in a more precise way to give patients better outcomes. So we're going to talk a bit about that tonight here. First, a little background on myself. So I've been an orthopedic surgeon here at Bluegrass for about 3 years. I did my medical school training in Philadelphia. So this is a bright sunny day in Philadelphia, not the winter snow that they have now, at Drexel College of Medicine. After that, stayed in Philadelphia and did residency at Hahnemann Hospital. That's right in downtown Center City, Philadelphia. There you can see the major highway kind of running along the side of the hospital, 676. That's a major thoroughfare that runs right through Center City, Philadelphia. So we saw a lot of major trauma that came in off the highways, and it was a level 1 trauma center. Did a lot of great training there, and it was a great place to learn a lot about orthopedics. Following that, I moved on to a fellowship and focusing on just hip and knee replacement surgery up in University of Louisville. And that's when I was first introduced into robotic knee replacement. They had one of the first robotic total knee replacements in the country that was at that center. And so I was able to do a lot of training on it during my fellowship. Following fellowship, I started down here at Bluegrass Orthopaedics and been here since, performing mainly hip and knee replacement surgery and revision surgery. All right. So outline of the talk that we're going to have tonight, we're going to start with talking about osteoarthritis and what total knee replacement is in general. And then we're going to talk a little bit about patient satisfaction after knee replacement, robots in medicine in general, and then we'll move on to the specifics talking about the Mako robotic knee system and some of the evidence that's out in the literature that talks about why this is better for patients and will provide better outcomes for patients. So to begin, we're just going to do some of the basics of hip and knee arthritis. And some of this might be evident to some people, but just so everybody kind of understands what we're talking about when we speak about arthritis. So the basic definition of arthritis is inflammation of one or more of your joints. Right? Joints are the ends of your bones, so such as your knee joint, your shoulder joint, your hip joint. The ends of your bones meet and there's movement at those. That's a joint. And then inflammation is a body's reaction to injury or disease that can result in swelling, pain, and stiffness. So arthritis is that swelling, pain, and stiffness in those points of your body that move. People refer to osteoarthritis as wear and tear. It usually develops in the middle age and can slowly worsen over time. This isn't something that happens overnight. You don't wake up one day and suddenly have arthritis. It's a slow, progressive process. What happens is that when you're born with articular cartilage. That's that smooth cap at the end of the bone, and it helps the joint move easily back and forth. Cartilage is a pretty amazing thing. When we talk about things like friction, and there's a measurement in science called the coefficient of friction. It has to do with how easily things move back and forth across each other. You could imagine an ice cube sliding on a countertop has very low friction, where sandpaper trying to move back and forth would have something with high friction. As much as engineers and scientists have tried, they actually can't create something artificially that has a lowest coefficient of friction as cartilage. It's that smooth, and it really functions great in our joints. Unfortunately, over time, that cartilage that protects the ends of the bone can wear down, and that's when arthritis sets in. The other great thing about cartilage is it doesn't have nerve endings in it, so it doesn't hurt you. When the cartilage does wear away, it becomes frayed and roughened, and then it exposes the bone that's underneath. And that bone that's underneath does have nerve endings, and so it becomes painful. And then to make up for that loss of the cartilage, the bone can form these outward growths or spurs called bone spurs or osteophytes. And that can be painful when the ligaments and tendons around the knee try to move around those things. Patients complain of pain and stiffness and swelling in and around the joint. They're usually worse in the morning or after periods of inactivity, such as sitting at a desk for a long period of time and then getting up. So this is going to be our first poll question of the night. And the question is, do you know somebody that's had a knee replacement? A simple question, yes or no. And I'm going to take about 10 or 15 seconds and let the people who are on the talk go ahead and try to answer the question. Okay.
Go back. You got to share your screen.
Good? Okay. All right. So we've got that poll underway with without too much technical difficulty. All right. So my guess is that most people would answer that they do know somebody that's had a knee replacement. And that's because arthritis is becoming a much bigger problem in this country. As people are living longer and staying more active, hip and knee replacement procedures in the United States have really increased. In 2017, there are over 1.5 million hip and knee replacement procedures performed, and that number is projected to go to over 2 million by 2024. There's even projections of over 3 million knee replacements needed by the year 2030. So it's definitely a major issue in our country, and can be pretty debilitating in terms of somebody's health if they suffer from severe osteoarthritis. So we've talked about osteoarthritis. Now let's talk about what a knee replacement is. And these are pretty basic concepts. A joint replacement can be either partial or total, depending on the location of the arthritis. And what we're doing in a knee replacement, whether partial or total, is we're giving you back what you lost. In those previous slides, we talked about that the cartilage, that cap on the end of the bone that didn't have the nerve endings, that was nice and smooth, has got worn away and you had painful bone underneath. And the knee replacement, what we're doing is we're replacing that worn out cartilage by capping the end of the bone with metal. So you can see on the side view of the knee, we put a cap on the end of the bone that's replaced where that cartilage is worn out. On the femur, we do the same thing on the tibia, and there's a piece of plastic that goes in between. These metals and plastics are very highly polished, similar to the cartilage that was in your body before it wore out. And the metal and plastic don't have nerve endings, so it doesn't cause you pain. We do a similar thing in a partial knee replacement down bottom, but instead of replacing all of the knee, we just replace the part that's worn out. So if the rest of the knee, including the kneecap area or the lateral part of the knee, isn't worn out and your ligaments like your ACL and your PCL are intact, then we can just do a replacement on, say, the inside part of the knee. And this is a great option in patients that are indicated for it because the knee tends to feel more like a natural knee. Recovery is much easier. There's not as much soft tissue swelling, and patients have a more natural feeling knee that they're usually happier with if they're indicated for it, and can be a very good option. But again, the major concept here is we're replacing that worn out cartilage by capping the end of the bone with knee replacements. And the other way, the ligaments on the side of the knee, the LCL out here and the MCL here indicated by these strings or ropes, stay intact for you. So the question is, how do we get there? How do we perform that knee replacement surgery, and what kind of instrumentation are we using to get there? So conventionally, we use similar instrumentation to what is shown in these pictures. And to be honest with you, the instrumentation of how we put in knee replacements hasn't changed much in probably the last 15, 20 years. And surprisingly, it's actually pretty rudimentary. So we usually start over here on the left side of the screen where we get preoperative x-rays. You can see the inside part of this knee is worn out. The bones are almost touching each other. The cartilage there is really worn out and frayed, and there's some bone spurs that are started to form. So we preoperatively will template this and plan to make a cut that's perpendicular to the tibial surface. So we got the alignment of the tibia here. We're going to make a cut perpendicular to that. We measure approximately how much bone we're going to resect. And then we come into surgery, and we use an alignment rod similar to this, where it straps around the ankle. There's a rod that sits outside the bone and a stylus that comes over the top, and we can adjust how much bone we're going to resect by kind of moving this stylus up and down. Unfortunately, when we use this device, we're really almost eyeballing what we think is the center of the tibia, or what we think is the right alignment for this. It's not exact. It's not precise, because it's left to the human error and the human eye to say this looks like it's in the middle of the tibia, or this looks like it's aligned parallel to the tibia. And in some patients, especially patients that are a little bit overweight, that can be challenging to always know exactly where the bone is, because there can be a lot of soft tissue between the jig and the bone that we're planning on cutting. On the femoral side, we usually do something similar. We actually drill into the femoral canal, which causes bleeding and pain if we have to put an alignment rod inside this bone before we can make cuts off of that alignment rod. And again, that alignment rod can sit not perfectly. It can be sitting up on some soft tissue, and the entry point for this drill could be off by a millimeter or two. And those things add error into the precision of what we're trying to accomplish with knee replacement surgery. And this is a view from the side of, again, a stylus kind of going over the top to size our femur, so we know what size femur to use and how to put it in and what rotation to put it in. All of these things are very important. And again, we're kind of doing it based on eyeball and measurements, where soft tissue can get in the way and it can be not as precise as we'd want. In the end, we hope for a picture like this, where we have an aligned tibia, where the implant here, this white piece that you see here, this is the metal, and so that is aligned in that perpendicular fashion that we were aiming for based on our preoperative template. But all of this conventional instrumentation that has not changed much in the last 15 or 20 years is not as precise as we could be. So those are kind of some of the cuts that we make, and then another cut we make to install the knee replacement is based on the rotation of the femur. So this is a view of the knee with it bent. So you've got your tibia bone down here, and you've got your femur bone here, and you can imagine the femur's kind of going up this way and the knee's bent at 90 degrees. Now, this is probably a little bit too complex, but there's some anatomic landmarks that we use and reference during surgery to try to align the component in the replacement that we're going to put in to try to match your anatomy. And our goal here, you can see the smiley face on the knee, is that we want to have this rectangle, this box, because you can imagine that there's ligaments on the inside part of the knee here and on the outside part of the knee here, and we want those to be balanced. You imagine if this box was much smaller on this side and much more open on this side, that we would have a not balanced knee, and it would be much tighter on this side and loose on this side, and that would make the patient not very happy. And so we want to try to get this rectangle. And we use these intraoperative landmarks to try to balance the knee and get that alignment right. But again, we're kind of feeling for these landmarks and eyeballing where they are in surgery, and we don't have a precision way to know exactly where they are all the time, so it doesn't always turn out perfect. All right, and we use, again, this is a picture of a jig that we can use to kind of put on the end of the femur, and it changes the rotation, size the femur to the size that we think it's going to be. But again, it's kind of looking at things where soft tissue could be in the way, or the anatomy could be a little bit different or hard to understand, and so we can be a little bit off in how we do this. And we're really talking a game of millimeters, or that we're trying to get these things so perfectly tuned in, and it's hard to do with conventional instrumentation. So this is a picture of what our goal is. So the femur straight up and down, so femur bone here, tibia bone here, with the legs straight, our extension gap. You got this nice even rectangle where there's the same gaps on the outside part of the knee here and on the inside part of the knee. So the MCL here, the medial collateral ligament and the lateral collateral ligament, those are equally tensioned. And then when we bend the knee to 90 degrees in this flexion picture, we have the exact same gaps. So the ligaments are evenly tensioned in both flexion and extension, and that it would be a happy postoperative patient if we're able to achieve that. And so how do we get there? And technology is, I think, one of the answers. So I try to point out a couple incidences where technology has really changed how we live everyday life. So if you were going to get countertops, say, installed in your kitchen, 15, 20 years ago, somebody would come out like this and measure it with a ruler and say, this is, the size countertop we need, and we're going to go to the shop and cut it and come back. Today, they come out with these laser marking tools, and they're able to measure these things in 3 dimensions and to, sub-millimeter accuracy that allows them to kind of precisely be able to put these things in a way that there aren't gaps or areas that they got to fill in, and they fit really perfectly every time. And if you were going to spend thousands of dollars to get new countertops put in your kitchen, you'd want the more precision way. And I think you probably want the same thing for your knee replacement. And look at phones. 20, 30 years ago, this was a rotary dial-up phone that would be in your house. Now today, my 7-year-old has a computer that she can access in her pocket and make phone calls with, that can do calculations, can get on the internet, can play music, can do anything in the world that you want it to do. And so it's just technology making, us better and, making us more available and having more options. If you were going to go on a road trip or drive somewhere that you haven't been before, again, 15, 20 years ago, you probably would have brought out the road atlas and, planned out your map and said, looked at all the streets that you're going to take and wrote down the turns you're going to make. Today, you plug into your GPS, your Waze app, your Google Maps, and it tells you the best time to leave. It tells you how to avoid traffic. If there's a police hidden ahead that's going to catch you in a speed trap, and you arrive where you were going probably safer, quicker, and more efficiently. So it's just an example of how technology has kind of, improved what we're able to do in life. And the same thing, in the automotive industry. In the early 1900s, people were assembling cars by hand and putting these things together. And now we've got these giant robotic arms that are able to assemble cars and put things together more efficiently, with more precision, and more reproducibly. So it's a bit odd that in knee replacement, we haven't had that same evolution of technology in terms of our instrumentation of how we put things in. Now, the evolution of the prosthesis actually has changed a whole lot, and there's been a lot of technology that have changed how the implants that we put in, but not necessarily the technology we used to put them in with precision. So this was the original total knee replacement, one of the first ones put in the country. And it had one size for the tibial component, and it had 2 sizes for the femoral component. There were no cutting jigs. Everything was done by hand, and you just had to make it fit for the patient. Today, there's some companies out there that have 38 different femoral sizes that we can use to fit a patient, and 10 different size tibias. And the plastic piece that goes in between can come in up to 1 millimeter increments and can vary up to 20 different sizes. So we've got a lot of different options in terms of the implants, but the technology of how we get those implants in hasn't really revolutionized or changed until recently. All right. And so next section, so that's knee replacement and kind of where we're at. And so next thing we want to talk about a little bit is patient satisfaction. All right, so we got another poll question here. I'm going to have Andrew pop up for us. Do you know someone who is unhappy with their knee replacement? Again, another simple yes or no. And while I guess we're waiting for that poll to happen, if anybody has any questions from the talk so far that you'd like to throw into the chat, might be a good time to type them in. Andrew will feed them to me, and I can always answer them for you. I can't see the results.
Yeah, 58% unhappy.
Okay, so 58% of people know somebody that's unhappy with their knee replacements. All right. Do you see my screen again? Okay. All right. We're a little bit better on the tech on that side, getting it. All right. So 58% of people on the call right now know somebody who has had a knee replacement and isn't happy with it. And that's not uncommon. So this was one of the landmark studies that came out in orthopedics, came out in a journal called Core, Clinical Orthopedics and Related Research in 2006. And it looked at patient expectations and satisfaction after knee replacement surgery. And what they found was that while 75% of patients were satisfied or very satisfied with their knee replacement, there was a pretty large percentage of people, 14%, that were dissatisfied or very dissatisfied with their knee replacement. Satisfaction was correlated with younger age and absence of residual symptoms, fulfillment of expectations, and their functional impairment. And I think this percentage really comes down to the precision with which we're able to execute the knee replacement. I think the implants have improved. The issues with that we've had in the past with our implants not being up to quality and having failures of the implants have greatly improved. But I think when we're not perfect and where you can't get to that millimeter of precision with manual instrumentation, that it leads to these patients where those gaps that we showed weren't balanced. And when those gaps aren't balanced, then the knee doesn't feel natural for them. It isn't function well for them. And when younger people that are more active are seeking knee replacement surgery, their functional level is much higher and they demand a higher level of function out of the knee. So if you're 85 and have end-stage arthritis and you can really only walk with a walker, and we do a knee replacement on you, and your only goal is really just to be able to kind of walk on a flat ground, most of those patients will be satisfied with the knee replacement. And when we were doing knee replacements in the 80s and 90s, that was a lot of our patients. Now there's younger patients that are active that want to get back to things like skiing or mountain biking or hiking. And those patients aren't going to be happy with the knee that they're trying to be active on if the knee isn't balanced well. This is, a summary of 6 other studies that showed very similar results. Satisfaction after knee replacement surgery. And as you look down the line, they're really in that 75 to 85% range, and that means that there's a 10 to 15% of patients that are not very satisfied after the knee replacement. And so when these studies really started to come out, people want to figure out how we can do knee replacement surgery better. And so some of the reasons that people aren't satisfied after knee replacement surgery can be alignment issues. So again, we talked about those conventional jigs. They're not perfect, and people can have their knees put in the wrong alignment. So this was an example of a patient that came to me, had surgery done by another surgeon. And if we look at her alignment of her knee on standing x-rays from her hip all the way down to her ankle, on her side where she didn't have surgery, we draw a line from the hip that goes all the way down to the ankle, and that line falls right in the middle of her knee, which is great. That's good mechanical access of her knee. The knee replacement that was done was put in and not a great alignment. And so when that happens, that knee replacement is fallen way outside of that center of her mechanical alignment. And so this knee is not going to be very functional, and she's not going to be happy with this. This is a picture of her leg in our office. It's my hand there holding her leg, and you can see the one leg straight up and down and this one coming off to the side. And so that patient's not going to be happy with that knee. It's not going to function very well on that knee. And that means she needs a revision knee surgery where I've got to take out her implants, put new implants in to straighten out her knee. All right. And our goal is to try to avoid patients having to have that revision knee surgery. A second issue is instability. We talked about those gaps in the balance of the ligaments in the knee. And I would tell you that this knee replacement on x-ray looks awesome. The alignment looks straight up and down. They've got the fit of the knee replacement perfectly. And, this is one of those x-rays where you say that, hey, they did a great job. They aligned this knee great. But what they weren't able to accomplish in their replacement surgery was balance of the knee. And so when this knee is bent at 90 degrees, it's got a lot of instability there. That ligament is not tight and it's able to shuck back and forth. And you can imagine if that patient tries to be active on it, tries to hike, tries to go for a bike ride, and has that much instability, it's going to keep bumping up against their ligaments and cause them pain and dissatisfaction of their knee. And so, is there a way for us to get better at that? So we look at robotics. As we're in a robotics, a way for us to be able to perform these surgeries better. And robotics in medicine, one of the first robots that was used kind of in a large fashion was the Vinci Robot. This one was approved by the FDA right around 2000. And the way the Da Vinci robot works, which is a little different than the way our Stryker Mako robot works, is that the robotic arms here are by a patient to perform the surgery, and the surgeon's actually at a console, not scrubbed in, not in the surgery with the patient, but controlling those robotic arms from this console separate from the patient. But it did revolutionize the way gynecologic and urologic procedures were performed in this country. And people removing prostate or prostatectomies were performed in the U.S. and just in 10 years went from 1% robotic to almost 90% robotic. And the reason is they were able to do it at a much higher level of precision with less soft tissue injury, so people recovered faster and had less complications. And once the evidence came out for that, it really became the standard of care for the way to perform a lot of these urologic and gynecologic procedures. So people thought, well, if they can do that in urology and gynecology, is there a way for us to do that better in orthopedics as well? So it's 15 years now, this company called Mako was developed in Florida, and they started saying, if we had this robotic arm, would it allow us to do our surgeries with more precision? So it's been around for a really significant amount of time, which is great because it means it's got a long track record. Other companies have come out with ones recently to try to catch up, but this by far has the longest track record in clinical evidence. This number is probably closer to 1,000 systems now. The slide's a little dated that have been installed. There's one in every state in the United States and across 26 countries worldwide. They've got a Mako robotic system. It's interesting. Lexington's actually one of the largest metropolitan areas in the country until recently that didn't have a Mako robot. And so I'm really excited that Bluegrass Surgical Center has been able to acquire one to be able to help patients in this area with their knee replacement surgeries. This number is probably closer to 400,000 now. Mako procedures have been performed. And there's this huge amount of published peer-reviewed studies about the efficacy of the robotic system. And I selected a couple of them to go over with you guys tonight so that you understand the evidence behind why this is a great system and a system that can really help improve outcomes in our total knee and partial knee replacements. There's another study about looking at robotics and total knee replacement. And again, there's a lot of people out there that try to project these things and predict what's going to happen in the future. But there's some projections that think by 2030 that 3 million of those knee replacements that we talked about were going to be performed, about half of them would be performed robotically. In the New York State system, they've got a good tracking system that follows patients and follows the patient's surgery. And they saw a 500% increase in robotics from 2009 to 2013. So it shows the amount of growth. There's these hospital volume trackers that do these surveys about hospitals and hospital administrators on whether they thought they were going to look at purchasing surgical systems like robotic knee systems. And about 74% were looking at purchasing a robotic knee system. especially those larger 300-bed hospitals we're looking, almost 94% of them were interested. The hospital systems are realizing that the patient outcomes are better and patients are seeking this technology because the evidence is out there that they get better outcomes with it. So move on and talk a little bit more specifically about the Mako knee replacement system in general. All right, we're going to pause before we get there and do another poll question here. Are you considering a total knee replacement in the next 6 months? Again, another simple yes or no. And again, if you guys, I know that was a lot of information to go through and a lot of data about the kind of the history of the knee replacement and everything. So feel free to type anything into that chat box. If you have any questions, we can answer those as we go through the talk here. All right. So looks like we're a little split down the middle here, about 50-50. All right, my screen back up. All right, good to go on my screen too. We're getting better at the technology here in terms of getting our poll questions and back to our talk. All right. So with that in mind, I want to go over the details of how we perform this robotic total knee for patients. And so it's a little bit complex, and so there's a lot of kind of steps to it. So we'll kind of go through each step independently. And this is where I anticipate some people might have some questions. So feel free to use that chat box and type away and ask any questions about the technology here and what we're doing. I'm really passionate about this stuff. I love answering questions on it. So you're not going to interrupt me at all. So the workflow here for the total knee is we start with a preoperative plan. And so that means you get a CT scan, a CAT scan of the knee before surgery. And based on that CAT scan, we're able to get a three-dimensional view of your knee. And then we can plan how we're going to put a knee replacement in to match your anatomy specifically. We can size it. We can adjust any rotational things that we need to do to match your anatomy specifically and come up with an idea of what is going to fit you the best and what implants are going to be the right implants to fit your bone. And so that's a huge part of it, having that CT scan preoperatively to be able to perfectly know and assess your bony anatomy of your knee. It's a really powerful thing that, and this is really unique to the Mako system, having that pre-op CT scan. Okay, so once we have that pre-op CT scan, then we come to surgery with that plan. Now that plan's not final, and we almost always will make adjustments to that plan, but the plan's really helpful, good place to start. So then we come to surgery. So in surgery, we actually place these pins. So there's pins here that go into your tibia and pins here that go into your femur to help get a stabilized point. And then we attach these, they're called arrays. And there's one here and there's one here. And so this is a picture intra-op of surgery where you can see that there are arrays here placed on the tibia and an arrays here placed on the femur. And there's actually an array on the robot. And these are very high-tech arrays. And what they allow you to do is to map out the bone in the knee. And so what we do is we actually see this blue line here. That's a probe that we bring down to the knee, and we map out the inside of each patient's knee, and we correlate those spots to where they were on the preoperative CT scan. So we're able to exactly and precisely map out the inside of the knee to match their CT scan that we had planned preoperatively. And so once we map out the inside of the knee and we have these arrays placed in the knee, then the robot and the computer system is able to know exactly where your knee is in space. So anytime we move the knee, these arrays will move, and they do this complex calculation every time it moves, and it's able to know exactly where each part of your knee, whether it's the femur or the tibia, are in space. And that's really helpful for us. So we've got this plan with the pre-op CT scan, but now we've got extra information that we can add in. And so the way it works is those arrays will send that information to this camera stand. This camera stand is across the table from the patient, and it's capturing all this information in real time and showing it to us on a screen. So we know how straight we can get the knee, how much we can bend the knee. And then the really important thing that we know is the ligamentous balance. And this is where we can balance those ligaments so that the knee is really going to be very functional for the patients post-operatively. So this is a very detailed screen, and it's got a lot of numbers on it. And I don't expect anybody out there to know what all these numbers on here mean. But what I'll tell you is that this is a screen that will come up for us once we have mapped out the bone and have those arrays placed. And what it is telling us where the knee is in space. And then it allows us to make adjustments. We can move the femoral component up and down. We can move the tibial component up and down. We can change the angle, what we call the varus or the valgus on the knee with the implant. So we can bring just the inside part of the tibia down, but leave the outside part where it is. All of these movements, we can change the rotation of the femoral component. We can change the flexion. We can change the slope. We have all of these options to precisely and perfectly put your knee replacement in a way that matches your ligamentous balance. And so this is the box here that I like to highlight your attention to down here in the bottom right. And what it shows us is that an extension, meaning with the knee all the way straight, medially, that's what the M means, there's 18 millimeters. And laterally, the L, there's 18 millimeters. And that 18 millimeters is the amount of implant that we're putting back in. We talked about a knee replacement, a cap that goes on the end of the bone. Well, that cap, if we did the math and added up all of the metal on the femoral component, all the metal on the tibial component, and the plastic piece that goes in between, it's 18 millimeters. So that's what we're shooting for when we do these knee replacements, is when we have the knee straight and when we have the knee bent at 90 degrees, that we make the cut so that these ligaments are balanced and that there's 18s and across the board, we call it, so that in both that flexion and extension, we've matched those gaps, and so those ligaments are evenly tensioned, and that's going to lead to a happy patient post-operatively. So once we are able to make those intraoperative adjustments before we've cut any bone, before we've made any trauma to the tissues, we are able to adjust all of those cuts so that then we come in and actually do the bone resection. And so historically, when we had the conventional instrumentation, we would make our cuts based on those jigs that we were using perpendicular to the bone, and then we would release ligaments. So we would use kind of actually make small cuts in the ligaments to be able to loosen them up, or remove or kind of release some of the ligaments from their attachments on the bone to loosen them up, so that we would balance those gaps. So instead of having to release those ligaments and let those ligaments go, we're able to plan our cuts of how we're going to put the knee replacement in so that we don't have to release those ligaments. And then we can go in and precisely do these bone resections. That's the other great thing about this technology, is that the bone resections are very exact. And so this is what we end up with. If we have those 18s across the board, we have 18 millimeters laterally, 18 millimeters medially in extension, and the same thing in flexion. And so we've got a very well-balanced knee. So overall, we've got this enhanced planning preoperatively with that CT scan, so we know what size and component we're going to use, and we have a great idea of how we're going to put it in to match your anatomy. Intraoperatively, after we map the bone, we're able to balance your joint without doing those big ligamentous releases that we had to do with conventional instrumentation. And then we have this robotic arm assisted bone prep. So that robotic arm comes in, and you can see that there's this yellow outline here. All right. And so that saw comes in and will make the saw cut for us in a precision way, where we're exact in terms of millimeters and angles of how we're going to make that resection. We're no longer basing this on our eyeball of this looks aligned well. It takes all that guesswork out of it. The other really neat thing is it's got these boundaries. Let's go back one. So we got these boundaries here. So you see this yellow line, and that saw won't go outside that yellow line. And what that yellow line is protecting us from is your medial collateral ligament here on the inside, your lateral collateral ligament here on the outside, and you've got some major nerves and vessels that run in the back of the knee back here. And so we bring that saw in, and even if you slipped, say you slipped on the floor and you ended up pushing the saw more than you thought you wanted to, it'll stop. The robot won't let you go past those things. So it really protects the surgeon from a lot of the soft tissues, and make sure that there's no intraop complications with cutting anything that not supposed to with the saw. All right. So all that sounds great in theory, all right, we've got this robotic arm. We're going to balance the ligaments ahead of time. Then we're going to make the bone cuts, and it should make us better. But, everything sounds good in theory. And the real question is there any evidence that it actually does what we think it's going to do? And so that's where, I think these publications I'm going to show you, I think are really telling in terms of, what the outcomes are for patients that have the robotic knee replacement surgeries. All right, so there's a lot of data on here, but I'll try to break it down for you so it's not so confusing. This was a study and they looked in cadavers, and they took 5 different cadavers, and they did 5 of them with manual, kind of the conventional instrumentation technique for the knee replacement, and they did 5 with a robot. And so if you look at this graph here on the top with the purple bars, the dark purple are the conventional instrumentation group. And these are actually all the cuts that we make to do a knee replacement. I know it seems like a lot, but we actually do make a bunch of different cuts to get that knee replacement in. And then the lighter purple, these smaller bars here on the bottom, are the ones that were done with the robotic-assisted knee replacement. And so what you can see is what they're measuring is what they wanted to take versus what they actually took and how much error there was. And you can see in those dark purple ones, much more error in terms of what they were planning on resecting, the angle that they were planning on resecting it at, and what they actually resected, where the light purple bars, much different. Those are much more even all the way across the board and much more consistent in terms of what they were able to resect. And this graph down bottom is similar to this graph. It's the same data, it's just kind of shown to you in a different way. And so what they did here is they took each one of those cuts, and each one of those cuts is kind of a different color in here, and they added them together, they summed them. And so what you can look at here is that if you sum up all of those errors, you end up with a pretty significant amount of error in terms of where the knee replacement ended up, and it's very variable. And these are the same surgeons that are very well trained that are doing these procedures. And you have this huge variation in terms of how much bone and what angle that they were resected at. You look at this one down here, the robotic group, that's what the RATKA means, robotic-assisted total knee replacement. And you can see how consistent it was across the board. Very little error in terms of what was resected, and it's very consistent all the way across the board. So very accurate with how you're able to resect the bone compared to manual techniques. All right. So if that accurate resection is true, then you would think that that would mean that we would have less soft tissue trauma. And so we talked about that we're not going to release the ligaments as much in this, but we're also going to make more precise cuts. And when we make more precise cuts and release less ligaments, then we should have less soft tissue injury. So this group out of England looked at how much soft tissue injury, comparing robotic knees with regular conventional total knees, and they showed that they had less soft tissue injury in the robotic knees. They looked at the femoral and tibial cuts in the bone resection and showed that they came up with this injury score and showed that there was less injury to the bone and the soft tissues than the conventional knee replacement. So with this robotic total knee replacement with the precision cuts, less injury to the bone, less injury to the soft tissue. So if you have less injury to the bone and less injury to the soft tissue, that really we would expect to affect your post-operative pain. And so when I was in fellowship, we looked at this and studied it, and we looked at a large group of consecutive robotic knees and conventional knees, and we looked at their pain scores. At 2 weeks, they had lower pain scores and required less opiates. At 6 weeks, it held true, still lower pain scores and less opiates. So similar groups of patients done at the same center with the same surgeon with the same protocols, but one robotic, one conventional, lower pain scores and less need for opiates after knee replacement surgery. This was another group out of England. And again, a lot of data on this slide, I know, but I'll try to highlight what's important. And again, they were comparing the same thing, robotic arm-assisted knee replacement surgery with conventional jig-based knee replacement surgery. And what I'll show you is that the fall in hemoglobin here, so that's the level of blood loss that you have after surgery, was better in robotic knee because we're having less soft tissue trauma. We're not drilling into that femoral canal like we talked about in the beginning, causing all that blood loss. So lower drop in what their post-operative blood levels were. Their pain scores on day 0, day 1, day 2, day 3, all better in the robotic group. How much pain medication they needed on day 0, day 1, day 2, day 3, all better in the robotic group. How quickly they were able to do a straight leg raise or lift their leg straight up off the bed, better in the robotic group. Again, less soft tissue injury, you're going to be able to do these things quicker. how quickly you were able to bend your knee and how far you were able to bend your knee, better in the robotic group. How many PT sessions you needed, better in the robotic group, and how quickly you're able to be discharged from the hospital, better in the robotic group. Again, these patients have less pain, they're up moving quicker and faster, and so they're able to get home out of the hospital quicker. All right, so improvements in post-operative pain because of less soft tissue damage, and patients recover quicker. Now, okay, great. If you can get a patient to recover quicker and have less pain, that's a really good thing. But long-term, are these gap balancing things that we've talked about able to really show any difference? And so we looked again, when I was in fellowship, we did this study and we looked at 53 consecutive robotic knees that we performed and how often we were able to get to this goal, this box of 18s, where you had the same ligamentous tension when the knee was straight and when the knee was flexed, both on the inside and outside of the knee. So out of the 53 that we looked at straight, 52 out of 53 of them, we were within a millimeter using this robotic technology. And we usually had to make some adjustments on our preoperative plan, 1 to 3 adjustments per case of moving things around. It was very common that we have to move things based on our preoperative plan. I almost always moved at least something. But in the end, we're able to balance these knees into this, balanced gap. So we're able to achieve that with this robotic technology, which is really great. All right. So if you're able to achieve that balanced gap, what does that get you? That's great. Can you achieve that balanced gap? But does that actually really provide better patient satisfaction after knee replacement surgery? And so this group looked at 6-month outcomes of manual versus robotic total knees. All right. And the WOMAC score here it's a little bit different of a scoring system where the lower the number is better. It's kind of odd for most scoring systems, higher is better, but the WOMAC lower is better. So throughout the robotic arm assisted compared to the manual assisted was better for short-term pain, physical function, and total satisfaction scores at 6 months. So that's pretty far out from surgery for these patients. Still to be doing better. And it's likely because we balance those gaps better. So we're able to balance those gaps more precisely. And so patients, even at 6 months, have better pain scores and better functional scores. This was a study that I helped publish, again, when I was in fellowship. And we did something similar. We looked at 75 consecutive patients with robotic versus conventional knee replacement. And we looked at those satisfaction scores. I showed you that paper in the beginning that showed that 75% of patients with conventional instrumentation were satisfied or very satisfied. And we came up with that exact same number. So this is, a tertiary care institution with, fellows, people that are training fellows, very high volume surgeons, and, still with conventional instrumentation, the very satisfied or satisfied patients were still at 75%. The robotic group were all the way up to 95%. They had higher knee society scores and satisfaction scores. And after you kind of got over our initial learning curve, our OR times are very similar across the with conventional and robotic total knee replacements. But this is pretty striking. With these conventional instrumentations, you got this 20% that are sitting here as neutral or satisfaction, and 7% that are dissatisfied or very dissatisfied. So, pretty striking graph there. And then that same group that looked at the 6-month function, they actually followed those patients out to 1 year to see if there was still a difference at 1 year. And they really did see a difference. And those WOMAC scores, again, manual versus robotic arm, the total physical function and pain scores were all better with the robotic arm assisted. And patients were really doing much better with those robotic arm assisted, and likely because we're able to balance those gaps so much better. And then quickly, just talk about partial knee replacement. I know in the beginning I showed you the difference between partial and total knee replacement. So with the robot, you can do both. You can do either the partial or the total knee replacement. So people have looked at the partial knee replacement as well. And this was a great study. It was a database study. So they looked at a group of patients that were all in what's called a Pearl Diver database, which is a database that looks at a specific insurance carrier. And they looked at all these patients that had either robotic partial knee replacements or manual partial knee replacements. Pretty big numbers. We're talking about hundreds of patients here, and looking at their revision rate. That's these blue arrows I've highlighted here. And so the revision rate at this for these 200 robotically assisted partial knee replacements was really low, less than 1%, where the manual was over 5%. So really big difference in terms of people needing revision after partial knee replacement. And then this study actually just came out at our latest, we call American Academy of Hip and Knee Society meeting that was in November, where we looked at survivorship and patient satisfaction. And so Dr. Roche, he's down in Fort Lauderdale, and he was one of the original founders that started using these Mako robotic knees 14 years ago. And he's been able to really follow his original group of patients. And so he's followed about 185 of them with 10-year follow-up. And 10-year follow-up is really hard to get in orthopedics. That's a really great long-term study that, to track patients that long is great, that we're able to kind of follow them and see how they do that far out. Because our real goal when we do a knee replacement is we want to have this implant last you forever. And so to be able to follow these out long out is really shows a lot. So the survivorship in this study at 10 years was 98%. One patient ended up having to convert to a total knee replacement because they had arthritis progress on another part of their knee, and one had acute infection. So you take out the acute infection, and the survivorship's even higher, just one that got converted. And then we look at this satisfaction. So 81% were very satisfied, and 97% were in the satisfied or very satisfied, with very few people having any dissatisfaction at all. So pretty remarkable data here for 10 years out, partial knee replacement. And these were all done with robotic assisted. And you really won't find this type of satisfaction in manual instrumentation. All right. So overall, in summary here, we're kind of getting to the end of the hour. Robotic assisted knee replacement. And what it does is it gives us more accurate and precise bone cuts. It protects our soft tissues and limits our soft tissue releases. Because of that, patients have less postoperative pain and they're up moving quicker. We got exact implant sizing, and we're able to put those implants in a balanced way that improve patient reported outcomes and functional scores. And then in our partial knees, we've really shown that there's better survivorship and outcomes in a partial knee replacement compared to manual instrumentation. So I really think that in the future, just like these studies have predicted, that the knee replacement is just going to continue to evolve. We're going to need to do more and more of these as our population continues to age but stay more active, and using technology to allow us to be more precise and exact about how we're able to put these parts in is really going to improve our outcomes of our patients and allow our patients to do better and be more active and be more satisfied with their knee replacement surgery overall. All right. And so now I know the chat function wasn't too active tonight, but if anybody has any questions, you guys can feel free to type them in. I think Andrew's telling me that there are some questions that we can answer. This is my crew. I got 3 little ones at home. So we got Eleanor, who's 7, Ryan, who's 5, and Maggie, who's 3, and our dog, Chara. All right.
All right, Doc, thank you for such a great presentation with a lot of information. We actually did have a fair amount of questions come through. First one, if I have a traditional total knee replacement, can my other knee be replaced using the robotic-assisted method? And the same person asked, what physicians here do this procedure?
Thanks, Andrew, and thanks whoever wrote that question. Really great question. Yes. So if you have had, say, your left knee replaced with manual instrumentation, and your right knee has arthritis but has no replacement in it at all yet, you're a great candidate for Mako robotic total knee. There's no contraindication just because you've had a knee replacement on the other side that use manual instrumentation. You could definitely use robotic technology to help you with your second knee replacement. Absolutely. I actually, one of my first patients that we've done here at the center was exactly the same case. She had her, it was her right knee that was replaced by me about 2 to 3 months ago, and then she had done really well from that knee replacement, was coming back to get her other knee replaced, and it's common for people to have arthritis in both knees. There's some genetic component to it, and we performed her left total knee replacement, and she did fantastic post-operatively. I talked to her the day after surgery, and she was ecstatic. She said, this is night and day different than the first surgery I had, and she had done really well from her first surgery, but she said she had almost no pain. She was just taking Tylenol. She was ambulating around, doing really well post-operatively after going home the same day of surgery. And then the second part to that question was what other docs in our group will do the surgery here. And so there's going to be in our group, myself, Dr. D'Angelo, Dr. Huff, Dr. McGonigle, and Dr. Christensen that will be the ones certified to be able to do Mako robotic total knees. Because I had a lot of training in my fellowship, I was already been certified. So I started up our program here and started doing robotic total knees at Bluegrass Surgical Center. And so the great thing is because of my training and having a lot of experience with it, I'm kind of getting the program going and training a lot of the staff. And it's taken away that learning curve. So the staff's really up to date on how to do it. And so when the other docs are certified to start doing the knee replacements as well, our staff's going to be really well trained and be able to accomplish these knee replacements really well for us.
Thanks, Doc. We appreciate that. I have a question from, I think, a physical therapist. He gets a lot of questions about what type of metal is used in these replacements. And also he's asking, does the robot mean less anesthesia time during surgery?
Okay, so two questions there. So the first one is the metallurgy, or what the metal is made out of in the knee replacement. And so that varies depending on the manufacturer. The knee replacements that we're talking about here, because the robot is kind of done by Stryker. So the Stryker knee replacements are mostly, the femoral component is made out of a material called cobalt chrome. It's an alloy made up of different metals. And the reason they use that metal specifically is it's very hard, and so it doesn't deform much at all. There's softer metals like titanium that deform a lot easier, and we don't want a metal that deforms. We want a hard metal that's highly polished. And then there's that piece of plastic that's in between. And then the tibia, sometimes the tibia is made out of just plastic. Sometimes the tibia is made out of a substance called titanium. And sometimes the tibia is made out of another cobalt chrome alloy. Most of the tibias tend to be made out of a titanium product. That titanium is a little bit technical on metallurgy, but you imagine that the tibia's got this flat tibia that you're putting onto the bone, and you want that to match the stiffness of your bone. And so the cobalt chrome, when it goes on the femur, it's kind of three-dimensional on the femur, so there's less stresses that go across it. But when you put it on the flat tibia, there's a lot of stress that goes across it. So you want a metal that matches the stiffness of the bone a little bit better. And so the titanium or the all plastic tibia components are a little bit better at that. So we've learned that about the implants. But so try to summarize that, most of the femoral components are made out of cobalt chrome. Most of the tibial components are made out of titanium, but there's definitely variations depending on the manufacturer of the knee. But I would say that almost all of them are very safe to have inside of a patient. It's very rare that people have any kind of allergic reaction to the metals or anything like that. It's really just kind of super rare case reports have been documented in the literature of true allergies to the metal. So the companies have learned a lot, and the major 5 or 6 companies that make knee replacements make very good, high quality knee replacements that can function real well on anybody. And then the second part of the question,
anesthesia time.
Oh, anesthesia time. Yeah. So in terms of how long it takes to do the procedure, when we were in fellowship, once you kind of got over the learning curve, we were either time neutral compared to conventional instrumentation or a little bit faster. Once you get pretty comfortable with the balancing part of it, and the people that are working with you kind of know the steps, you actually can become a little bit faster, but it's pretty close. Most people are either even or a little bit faster with the robot once they've kind of gotten over their learning curve. So if it's any faster, it's only a couple minutes. They're pretty similar in terms of how long people are under anesthesia for.
Does Medicare cover the surgery?
So that's another great question. Yes, Medicare covers the surgery. It covers the CT scan, and Medicare is covered at our outpatient surgical center, Bluegrass Surgical Specialty Center. So yes, Medicare patients are definitely candidates for the knee replacement surgery with. Okay.
Another question here. Do you have to make as large of an incision when using the robot?
So in terms of the incision, we use a standard incision, and so the incision's about the same length that you would have with a conventional instrumentation. We actually have to make a small extra incision further down on the tibia to be able to put those pins in where the array is attached. So you actually have two little poke holes that are a little further down that are extra, but other than that, the incision for the knee replacement is really pretty similar to what we would use in conventional instrumentation.
Thanks, Doc. And we have another one here. What do patients report post-operatively as far as pain from the placement of the arrays, specifically the tibial array?
So really good question. And the idea is that if we have to put these arrays in the tibia, let me go back to kind of show you the picture of the setup, and that might kind of explain to people what the everybody's talking about here. I think this would be a good picture. So it's hard to see, but there's two pins here that go into the tibia, and that's that kind of extra incision. And this one, they put the pins in the femur as well. We actually put those inside the incision on total knee replacement, so you wouldn't see that. But these ones in the tibia, we need them to kind of be out of the way of the incision in the saw, otherwise things get blocked. And so patients ask about that, and are there any complications with putting these pins in and that kind of thing. And they're actually very little. So we inject some pain medication, some numbing medication in here, and patients have very little pain or very little side effect of any kind of complication here. There's very few wound healing complications, and people have studied this a lot because they said, hey, this is something that we wouldn't be doing conventional total knee, and does it cause any extra complications? And it's exceedingly rare to have any issue or a complication with those pin sites.
Thanks, Doc. We have another one here. I have been told that if you have a partial knee replacement, you will eventually need a total knee replacement. Is this true with a robot? Can you have one knee with a total knee replacement and the other with a partial knee replacement?
So I would tell you that the evidence behind partial knee versus total knee is a little bit all over the map. And if you look at large registry studies that can include everybody, that there is a little bit of evidence that partial knees don't have the same survivorship as total knees. If you really tease out that evidence and look at centers that do a lot of partial knees, and actually in people that are high volume in partial knees, the evidence is that the revision rate in needing a total knee replacement down the road, the rate of revision for partial versus total is exactly the same if they're done by somebody that is high volume and does a lot of partial knees. The problem is when we look at registry data that kind of takes everybody in, if you've got this surgeon that say does one or two partial knees a year and isn't very familiar with the instrumentation, that they can have some complications. The other thing is if somebody has got a partial knee replacement in and it's painful for whatever reason, people are quicker to revise that to a total knee than if somebody's got a total knee replacement in. That's a much bigger surgery to revise. So I think people are a little quicker to revise partial knees than they are a painful total knee. So with all that being said, if you look at the data and the evidence of partial knee replacement done for the right indications by high volume surgeons, their survivorship's exactly the same as a total knee replacement. So getting a partial knee replacement does not mean that you're going to need to get it revised anytime in your lifetime. They can last people for 25, 30 years, and they do very well with them. And I'll point you to that last study that I showed where the Marchand's data, where these patients are 10 years out, their survivorship's almost 100%. Pack one, and one of them was for acute infection. So, if you've got 185 people at 10 years with almost 99% survivorship, that's pretty remarkable data to look at about how these things will last. And I think you also asked if you had a total on one side, could you have a partial on the other? Absolutely. Just because, and what it really comes down to is preoperative assessment of where the arthritis is in your knee. I tell patients all the time that if you just have arthritis on one part of your knee, then, we can't give you anything better than what God gave you. And so if, there's no sense in replacing the kneecap joint or the outside part of the knee if that cartilage looks great. So we just replace the part that's arthritic, and patients really, if you're a good candidate for it, a partial knee functions better for you. Patients are able to do more. They have better knee satisfaction scores. They recover quicker, and they're usually happier patients. But you just got to make sure that you're doing them for the right indications.
Thanks, Doc. I'm going to give you two questions here. One, does the surgeon's experience with a robot machine matter on the outcomes? And two, explain outpatient recovery versus hospital.
Sure. So surgeon experience with the robot, it's a really good question. I would tell you that a surgeon that doesn't understand how to do knee replacement surgery, a robot won't make that surgeon any better. But a surgeon that really understands knee replacement surgery can really do a great job with the robot and can make that surgeon even better than they are. So the robot, it's not like we walk in the room, turn the robot on, push a button, and go have a cup of coffee while it does a knee replacement. The surgeon's incredibly involved in this procedure and are making the adjustments intraoperatively to make sure that knee comes out perfect. So I think it makes a good surgeon great. But if a surgeon, you can still have a bad outcome with a knee replacement done by a surgeon that doesn't really understand how to do a knee replacement. But I think if the group that we have here at Bluegrass are exceptional surgeons, and they can, this robot and this tool of instrumentation will allow us just to do what we do even better. And as long as you have a really good understanding of knee replacement surgery, even from the beginning, you might be a little bit slower in terms of how long it takes you to do it until you kind of get some of the steps down. But it's one of the really neat things about people that implement the robot is that they almost immediately get better patient satisfaction. Now, the speed at which they do the case takes a little while. That's the learning curve. But it's not a learning curve in terms of patients having complications. The patients do well from the beginning. It's just a learning curve in terms of getting their steps and being efficient at doing the replacement, so you can get it done a little bit quicker. And what was the second question?
Well, actually, to piggyback off that, before I ask that, how long is the surgery typically? I think you mentioned that, but also explain outpatient versus hospital.
So most knee replacement surgeries take somewhere between 45 to 90 minutes to perform. I'd say the average is probably in that 50 to 70 minutes. A little bit depends on whether we're using cement or press fitting and other kind of variables that go into it, but that's about the average, and that's pretty standard robotic or conventional once people are kind of up to speed. So that's about how long they take. And then the other question about outpatient versus hospital stay. And so, one of the things that's really been revolutionary in hip and knee replacement surgery over the last, 5 to 10 years has been outpatient surgery. We've gotten much better at blood loss, pain control, and our anesthesia techniques. And so if you had your knee replaced 15, 20 years ago, you'd stay in the hospital for 5 days and then go to rehab for a week before you'd go home. And now, because we've improved so much at our pain control stuff and our blood loss, that we're able to do these surgeries and get people up moving right away and get you home. And so for patients that are healthy without major cardiac comorbidities and things like that, there really isn't a need to stay in a hospital overnight. You're going to be a little bit sore after surgery, but you're not sick. So if you're not sick, there's no reason to surround you with other sick people at the hospital. And almost all of my patients that have the surgery and go home the same day are really happy they did. Especially now with COVID going on, but even before that, the patients are more comfortable recovering in their own home. They don't have a nurse coming in at 2 a.m. to check a blood pressure on them when they just fell asleep. And we get therapy out to your house the next day to work with you. You're in constant contact with our surgical center. We have an on-call nurse that's available 24 hours a day to answer any questions that patients have that come up. And so we're really good at doing these surgeries outpatient. We've done over 1,000 hip and knee replacements at our surgical center this year alone. And so we've got a great system with a very low complication rate that the patients do really, really well with outpatient surgery at our institution.
Thanks, Doc. That was great. I have one question from an individual who I think knows a little bit about the Makos and may not know the cost. So is there a plan to get more Mako robots at BGO since so many surgeons will be utilizing this technology? We understand there was a great commitment from Bluegrass Specialty Surgery Center on this, but the question is, are we going to get more in the future?
So the question is, are we going to need more robots at our surgical center in the future? And I can't say 100% yes or no. I don't have a crystal ball, but if I was guessing, I would say yes. I think, watching where I had done fellowship 2 years ago, we had a robotic total knee, or 3 years ago now, system, and they about 3 or 4 months ago got their second one. And most centers that get this robot end up getting a second one at some point, 2 to 3 years afterwards, because so many patients come in looking for it. There's so many surgeons are happy with the results that they're getting with their patients. And there's a huge demand for it, and one system isn't enough to keep up with that demand, and so we end up having to get a second system in order to supply the demand of what the patients are getting. So most places across the country that have placed one and have surgeons that are champion it and use it end up needing a second system at some point in the future, because the growth is really there for it.
Thanks, Doc. I think that wraps up the questions, I believe. Let me check that chat box just to make sure, and I believe we're good. Now, to finish up, why don't you share with the audience how they can get a hold of you, how they can schedule with you, and just go from there.
Absolutely. So our offices are on Richmond Road. There's if you go to our website at bluegrassorthopaedics.com, there's actually a page on that website that's devoted specifically to the Mako robot. And there's actually some more information that you can read through, some more studies. If you want to read through some of the publications that I've published, or that other physicians have published on the robot, you can read through that medical literature. Some of it's a little bit complicated, but if you want to try to read through it, you can get some more information there on those studies. And then, through that website, there's an easy way to kind of click on a link and set up a opportunity to come in, see me in the office. We can talk about, anything that you need in terms of management of knee arthritis, and see if you're a candidate for knee replacement surgery. And the other physicians, as well as in our group, I mentioned Dr. McGonigle, Dr. Huff, Dr. D'Angelo, Dr. Christensen are all going to get certified here in the next week or so. And so we'll be able to, really serve the needs of the Bluegrass area with this Mako robotic total knee and partial knee replacement. All right. I want to thank everybody here for coming out tonight. We had a really good attendance and a lot of great questions from the audience. Really impressed with the questions. They make for a really good talk, and I appreciate everybody spending their Tuesday night listening to talk on knee replacements. I'm obviously really passionate about it. I could talk about it forever, but I hope this was informative for you, and it helps you understand what the robot does and why it does it, I think, a little bit better than conventional instrumentation. And I think Andrew posted a link in the chat too to the website that's got the specific link for the Mako robot page that you can learn more about us there. I hope everybody has a great evening and appreciate your time tonight.